Certainly. Thank you, Rana.
You're
It
welcome.
is great to be doing this again. You'll notice my chair keeps sinking, so sometimes I have to go up and down a little bit. I don't know if that's a sign of how the holidays went, but yes. So thank you for joining us. This is what we refer to as a recurring webinar. So this is a key pathologies where we utilize a different case to highlight how the product works. So this is very product centric, not sales centric, but product centric, where really we're going through not how to acquire the data, but more on how to read it and maybe look at it a little bit differently. It's a really exciting time because we've got some, we've had some changes to the organization. We've got a lot of new people. The product is just, I can't wait to so everyone can see some of the new stuff that's coming out, which I think will be interesting and very useful. I'll talk a little bit about that as we go forward. But so this is again more focused on the equipment, or I should say the utilization of the evaluation. So once the data is collected, there's a report that's generated, and you can view it either on your mobile device or on the online HTML app on your computer. I do this presentation from the computer, and so I share that online app, and which is actually the one that I use most of the time anyway when I'm creating reports and having discussions with my patients or other clinicians. And yes, I wear a hat when I treat patients too. So I'll be treating patients this afternoon. And anyway, so it's more focused on the product. So I don't really get into the process of taking the analysis. We've got videos and things like that. And so it's really kind of focused on the utilization. So this month's case, so we do a different case every single month. This month case is sort of a combination. So we're looking at fall risk associated with a chronic neurological condition. And I've talked about this case off and on a little bit in the past because it really addresses a couple different things. One is the condition. Two is looking at some pre and post data. Three is sort of justifying the treatment so people will commit to the treatment and be compliant, especially in most every country. So most every country has some form of reimbursement, so healthcare coverage, right? So it could be the government, a socialized medical system, but even then, a lot of us do some therapies that aren't maybe covered by the government, and therefore it's an out-of-pocket expense, and to create some justification for patients to continue that care or justify, the out-of-pocket expense, and in showing how awesome, we are as clinicians. So I'm gonna share my screen because if you've heard me speak in the past, it's very difficult for me to do anything without showing some PowerPoint. So I did make just a few slides to create some points here. And I do share the entire screen. So we're going to see sort of the matrix happen here in just a moment. And I'm going to start here. All right. And Rana will let me know if you guys can't see it, or if
Yes, we can.
okay.
Yes,
Or I remember one time I think I lost power or internet, and I probably spoke for about 15 more minutes before I finally answered the phone, and Rana said, you're talking to yourself. And I said, I'm good at it. So about me, so I'm a clinician scientist, and so I work in a lab sometimes. I'm teaching biomechanics this semester. I'm also a clinician, so I treat patients as well, and I focus a lot on performance-based outcome measures in terms of patient assessment. But as I was mentioning earlier, when we look at how we get paid, which is our job existence, then that's something else that I work with a lot. I work with a lot of clinicians and assisting them in doing that process. Um, so I span a few different areas of medicine and exercise and sports science. So in the reason I'm going to bring up like aging on gait and mobility, which we've discussed before, but the reason is when we're looking at some of these neurological conditions, it's important to be able to differentiate some of those factors associated with the process of aging, the influence of aging that it has on mobility, and in this particular, gait or movement patterns of particularly walking. And I've presented in the past, so I do a lot of cognition things as well. So looking at that connection between, cognition and motor ability, and it's bi-directional. So your lack of mobility has a potential negative influence on your cognition, and your cognition has potential influence on your ability to move appropriately. And it's an interplay between the voluntary control mechanisms associated with movement patterns. And the reason that we use gait a lot is because within gait, it really helps to address a lot of the systems of the human body. And so if you think about it from that health or performance perspective, it really provides us a lot of information because there's reflexes involved, you have cardiovascular system, you have voluntary control. It should be something that people are pretty good at because they've been doing it for a while. And that's where when we look at the implications or the effects of aging, being able to sort of tease out some of these things that might be associated with aging and not necessarily a disorder like a neurological disorder. So typical with aging, we do see some constraints. We see some compensatory mechanisms with regards to movement patterns. There's some degradation to vestibular and proprioception, the neurological mechanisms that help us know where we are in space and certainly help us to control with that. This is very close, near and dear to my heart because my mom in particular has experienced a lot of issues associated with aging and mobility and compliance. And so we see that, and then not always, but add on top of that potentially a neurological, associated problem with that. And so that can present itself similarly to some of the things that we might see as a result of aging. Also with aging, people tend to be less physically active, and that creates an automatic decline in a lot of these features as well, including strength. I work out, I exercise at a facility. My wife is a teacher at a private academy school. And so I have access to that, but I go in early in the morning, and that's the time when they have the community program. And so um, I'm the young stud. I'm a young person in terms of that group. And so it's interesting, to when people look at me a little differently. But what I had a discussion with just some of the folks last week was there's so many people on these balance apparatus now, and called a Bosu ball or a BAPS board or something like that. And definitely one of the components, right, where we look at stability, as a component or the ability to react to changes in your center of mass. And that's another problem with aging is they're not as good at estimating that change, or at least rapidly enough. And so one of the mechanisms, to reduce the risk of falling is obviously to have good balance, right? And the other problem, and I've presented on this with Gait as well, and this is really important when you're looking at it from a rehabilitation perspective of what can we do to reduce falling. So reducing the risk of falling is multifactorial, where yes, we definitely want to create a safe environment, but also when we look at the mechanisms associated with a fall. Losing balance is one thing, and I think I show a picture here in a moment, but I'm here in New Hampshire, so I'm in the northeast area of the United States, and right now it is winter, and we've been getting a lot of snow, and we've had a lot of ice, and so ice, creates a very low friction surface, and it creates an opportunity environmentally for people to fall. And in fact, I'm coaching youth baseball for an indoor league right now, and one of my other coaches, he's probably about 20 years younger than I am, and I had to throw batting practice last week because he had fallen on the ice. So age with the environment, can still contribute. But what we want to do after we lose our balance is we want to recover, and we want to recover quickly enough and generate enough force so that we can put our center of mass back in that position where we're going to be stable again. In other words, once we lose balance, we want to keep ourselves from falling. So we want to try and recover before we fall, because the problem is once we fall, then we have to succumb to the effects of gravity and the impacts that one may have with the ground or another type of device. So shifting gears a little bit and looking at neurological changes, and we have a myriad of conditions that we could discuss. Right now, I'm working very closely with a facility in New York City, and they focus on neurological conditions, specifically stroke, post-stroke, Parkinson's, Alzheimer's, and things like that. These neurodegenerative, progressive disorders and diseases, at least some of them, and then others, we may have a capacity either to slow down or we can change that direction a little bit. And so that could be a situation of like a stroke or spinal cord injury or something like that. And so when we're using mobility, and again, this is one of the tools, one of the assessments that we may use. So I've used it in terms of very similar to how I'll use it, with anybody else, is focusing on those particular metrics or biomarkers that have a relationship to that particular condition. I'm going to go to the system in a second, very quickly here. I promise you that, and I'll show you some things that you could do to create a filter for a neurological system. Actually, there's one that's already built in, but we'll talk about that in a moment. So we look at things like the walking profile, so your speed and your stride length, and I'll show you a little tool that I had developed because we didn't have it in the system. The swing and the stance, and a lot of symmetry. And right now in sports science, symmetry or asymmetry is under a lot of discussion right now in deciding that there's a lot of asymmetry in sport, which is true because there aren't many sports that are purely linear, like running 100 meters, for example, in track and field. Whereas these typical field and court sports are moving in many different directions. People will have a dominance and things like that. But when it comes to something as simple and basic as gait, where there's not an overt, a very large challenge, at least to maximal capacity, it should be pretty symmetrical. And so we can use that in a lot of these particular areas. So minimal toe clearance is another really big one, and that's associated with the risk of fall. So we see that as a problem because if they do hit their foot into the ground, they contact it inappropriately, that will cause them to throw off their balance and therefore potentially fall. With the neurological, it's a little bit more to do with not aging, unless they are aging and have a neurological problem, but more so to do with motor control systems, right? And looking at their ability to know where their foot is in space. Like I'm talking to a group of people here that you all know that. And if I tested every single one of you, you probably have perfect minimal toe clearance. And it's not just too much or too little, right? Because we're also a system of efficiency. And that's one of the things that happens in a lot of these neurological conditions is they've lost sort of that mechanism to control that and look at efficiency. So of all of these, and like with the asymmetry, we don't just look at right and left, we also look at variability. And so that's the repeatability. I often use heart rate variability as an example. In we use that to assess the autonomic nervous system, for example. So, looking at variability, too much or too little can actually be problematic. So, their foot position as it comes in ground contact, as well as coming into that toe off position and during the swing phase, because all of those factors are associated with motor control and eventually stability, right? As we're swinging through the air, eventually heel striking. So we want to heel strike appropriately. We don't want to scuff our feet. And there's a point where there's double support, and then there's a point where there's going to be that single support, which is a real challenge for neurological problems because they don't, when you're on one leg, you don't have the same stability. And especially if you have a neurological deficit. One of the advantages that we see in our system is the pronation supination variability as well. And that's one that's already embedded, and we do see that quite a bit. And so this is an example. You can see the picture over there, and the person falling. And so, how can we use this system as it is to create some sort of information with regards to increasing fall risk? And I'll get into a little bit more detail when we get there. But if we look at certain tests that are used, so in the United States, the CDC, the Center for Disease Control, they have a format called STEADY, and STEADY utilizes multiple different tests because it's not as detailed as looking at the scientific aspect of Gait, but using more performance-based outcomes and not so much the surrogate piece. But with our system, you actually do get into a lot more detail, and we can actually look at the toe clearance. We can look at the variabilities. We can look at the double support versus the single support. We can look at that walking profile. We can look at the symmetry, the asymmetry. And another one is, as you'll see specifically, I'm going to talk about is like the foot progression angle, because that has impact on not only foot toe clearance, but also with the foot in or heel strike position. I put a few extra slides in here. Maybe I'll talk about them, when we get back. But just as a note, not everyone, not every test, when you look at it from that lowest level perspective, is going to tease out enough information. And what do I mean by that? One of the things that happens, especially with gait and walking, and I prefer to do this over ground, but sometimes I will do this on a treadmill. So you can do this test over ground or on a treadmill. But on a treadmill, I can control something, and that's going to be speed. And so I can actually increase the speed and see how a patient responds when I make them walk faster. One of the things that happens is if you give someone the opportunity to choose a self-selected speed, they're going to do what's going to be most comfortable, typically, right? And so they're going to perform a little bit better than if you stress them a little bit. And if we think about when things tend to go wrong, it's usually when there's some level of stress. And another example of that is going to be dual task. And what we're doing is we're increasing their cognitive load. And again, I'll show you some slide after if we're interested in that. And I've talked about that as well, where we increase the cognitive load, and it has an impact on their ability to motor control as they're going through the gait pattern. So this is the online version of the application. And so this is my alpha. So it looks probably a little bit different than yours, but essentially it's all the same stuff. But so this brings up the dashboard when I'm at the home, and it tells you, some of your patients. It shows you your most recent activities, and then I can go over here to the column on the left, and we can see we've got some choices for the patient, the equipment, the settings, and the support. If I click on patients, it's gonna generate and populate my patient list. Equipment, it's going to tell me, what equipment I have and what sensors are associated with my particular account. Settings, you can change it from metric I'm in the United States, so we use the imperial units. And this is also where, you can add people or take people away from your workspace, so you can share some of that particular data. So I'm going to go over here to patients. And so this particular patient, he's not that old. He's in his 60s, and he had just retired. And he was used to be an avid tennis player, high level tennis player, and an alpine skier, a downhill skier. Um, up until he had a motor vehicle accident and he was rear-ended, so he was impacted from behind while sitting in his vehicle. So a very dramatic extension injury. So that caused an injury to his cervical spine at approximately C5 and C6, and it resulted in some permanent damage. He was paralyzed um, on one side completely for a while. It actually presents a little bit more like a stroke. It wasn't a stroke; it was a cervical spine injury, and but that left side was impacted. So when you see him, he presents as though he had a stroke because it's very asymmetrical, and so the impact, I from what we gather, he was turning in one direction, and so looking over that left shoulder, seemed to have more of an influence on the tracks in the spinal cord on that particular side, hence his presentation. So he presents with an upper extremity abnormality. So even as he's walking, he does not have good mobility. He has increased tone from the shoulder down into his hand. He can voluntarily move it, but he doesn't have really, really good control, especially when you look at sort of the reflexive nature of gait. He doesn't swing normally, and you can see that when I don't have the video, unfortunately, but you can see that on video, because instead of using an arm swing to create balance, right, and offsetting the difference between the right and the left profile, he uses a body motion swing, right, to kind of keep that balance in terms of shifting his center of mass from the right to the left. And then his lower extremity also has increased tone and some mobility issues as a result of that as well. And again, if you were to see him and didn't know his history, you would think that he previously had a stroke. So he was a patient of a colleague of mine. So we were in the clinic together, and we were working on this case because he had just retired and he was looking to enjoy retirement, but he has these limitations, and so now he's getting a little bit older, but also his limitations, is problematic because he can't do all the things that he wanted to do. So one of the reasons for bringing me in was to look at, is there some other things that we can do. I'd mentioned earlier this neurological facility that I've been working with in New York City that treats all these neurological conditions. So we've been using shockwave and laser, and it was very interesting because a lot of these patients have been there for years and years and years. This particular patient, this was 13 years after he experienced that spinal cord injury from the automobile accident. Okay. So it shows the dashboard of a particular patient. You can click on the patient profile and get all of the data. Practitioner analysis allows me to see all of his tests that we've done on that. I'll come back to the evolution in a second. So I'm going to go back to the dashboard. So what I want to do is I'm going to pick the first one, and this first one. So he actually rode his bike to the clinic, and I was waiting, and I watched him walk in, and again he presented as though he had a left-sided stroke, but he moves very rapidly. He has a lot of confidence, and I don't know if it's more so confidence or a desire to try and be as normal as possible. So 13 years after a spinal cord injury, we're not going to probably create any regeneration of the neurological tissue. And so the reason for us looking at this, was there a way that we could potentially look at, these other issues associated with this condition, which one is tone, because tone really was limiting his ability to move more appropriately. And we were looking at it from the perspective of, if we don't do something, does he progressively gets worse? And actually, we're going to be following up with this soon. So maybe I'll present this again, because it's been a couple of years, to show people that there is some things that you can do about this. So like I said, it's a left-sided problem, and you can see his symmetry here is very considerable. So it's off by 20%, and this is a self-selected speed. So what we see here, if it's in red, so this is part of the AI component to the platform, is red means that it is more than 2 standard deviations. If it's green, it means that it's within that 1 standard deviation or particular scalar of a normative value. If it's amber or yellow, it means it's between 1 and 2 standard deviations of the normative values. It's not ours. They're the values, taken from the literature associated with the research on Gait analytics. So we see that he barely is getting into a normal speed pattern. So despite his limitations or his condition, he can actually walk at a normal speed. But again, I wish I had the video, because if you see the video, you can see that it's a lot of effort, right? He's working hard, potentially to get that speed. But nonetheless, he has normal speed. This is still important to me too, because I talked about aging at the beginning, and when older adults walk slower than 2.4 miles per hour, it's actually indicative of potential metabolic or cardiovascular problems, because they're not walking at a fast enough capacity to really stress those systems and get the health benefits associated with being more active. So here we see, this is the walking profile. So the left is on top and the right is on the bottom. What's interesting is you'll notice that he has a longer stride length on that left or impacted side. But of notice is we see that his stance phase is approaching 65%, and his swing phase is 35. And so very different from the classic. At that walking speed, he really should be 60-40. Right, 60% in the stance phase and 40%. Now his double support actually looks pretty normal, okay? But again, just to think about this from the perspective that if he has this problem, why would he have a longer stride length on that side? And again, it's because he's working very hard to overcome his problem. But, the normal stride length is probably 47, because his right is going to be the normal side. And when we think about this from a complex motor theory standpoint, you can't go too much beyond the affected side, because he would keep turning to the opposite direction, if that makes sense. Kind of funny, but and so it's a literal holding back of performance, even on that good side, when we're talking about something that's supposed to be relatively symmetrical. So if you click on advanced, right, this is again where the AI piece comes in. And this is what's good, because it not only tells us what's normal or abnormal, it tells us which side, and it tells us if it's high or low. So we see that his stride duration is actually normal, relatively speaking. His swing time is normal on that left side, but it's really long on the right side. And the reason for that is, again, he's holding it back. So he has to compensate for where he's lacking on the opposing side. Okay. And the other reason for that is when you look at the stance time, because his stance time is really long on that affected side. And why would his stance time be long on that affected side? Because he doesn't have really good motor control or stability. So he wants to spend a little bit more time on the ground and less time in the air. And again, we see fairly normal, almost mid-normal on the non-affected side. And then we look at the gait line. So the gait line here is representing a center of pressure orientation. Now we don't have pressure sensors in the system, so we extrapolate that utilizing foot orientation, and it's posted against during the research and development of the product against pressure sensors. Okay, so this right side actually looks pretty normal. Okay, so we see that, we typically foot in or heel strike slightly calcaneal inversion. So on the lateral aspect of the foot, and as the foot goes into foot down, we want to transfer that and we get more of a neutral base of support. And then we're going to, there's my hand, and then, we're going to midfoot supinate again, but we transition over to the first and the second ray for toe off, right? Because that's where we have all the strength and the balance and pretty normal. But we do not see that on that left side. So he's staying on the outside of that foot as he's going through. And we will see when we look at the pronation and supination, the impact that that has, or I should say the impact that the pronation supination has on his gait line, in the way that his foot comes in ground contact and how he uses that base of support. Okay. So we also see, you can look at some of the information here, and you'll notice that he has excessive time spent, especially in the foot flat position. And that makes sense because more of his foot is going to be on the ground, and that creates a greater sense of stability. His propulsion rate is actually normal. So that's the ratio between the hip flexors and the plantar flexors. And that's measured, using the acceleration rate of toe off. So as we're going into that swing phase, and that's a ratio of acceleration or rate into that. And that gives us a number where we can compare hip flexors to plantar flexors. So in older adults, what's interesting is we tend to see more of a compensatory mechanism in plantar flexors than we do with hip flexors. If they don't have the stability, then they're not going to, one, create a lot of force anyway, but they're going to toe off. They're more comfortable pressing from that foot than they are trying to go into the swing phase. And so that's a compensatory mechanism we see in the literature. So then we can go up and we click on these details. And the details give us this pronation and supination angle. I'm going to click on advanced right away. But again, you can see this color orientation, that if it's amber, then we're seeing somewhere between 1 and 2 standard deviations outside of the normative values. If it's green, it means that it's normal. If it's red, it's more than 2 standard deviations. So a couple things to consider here. And so this graph is the graphical representation of these numerical values. So it's the same data. Now, this is where it is a little bit different, because in our system, and it's challenging to come up with normative values for all the different people wearing different footwear. So we create a neutrality, and then that allows us to create what we consider to have a normal foot trajectory as we're going through that stance phase. And that's what this green corridor is. So that is normal or neutral, including the standard deviations. So that thick line is the mean or the average. You can put your cursor over each dot and it shows you that. And then you'll notice it says min and max. That's actually the standard deviation, not min and max from a statistical standpoint. And so what we see here is those thin lines, that's the standard deviation. They're really tight, very, very tight. And we often see that in people that are extremely good at or comfortable with a particular movement pattern. The problem with that is that low amount of variability usually indicates a potential problem, with responding to a changing environment, right? In other words, if they were to come across an obstacle, or if they were to lose their balance a little bit, their ability to react most appropriately is going to be very, very challenged. If we look over here to the right in the toe off, That's actually a pretty normal distribution in terms of the standard deviation. That's what I would rather see. And interesting note, when you make changes, you will see that increase. Now, it can also increase dramatically, or we can see that standard deviation being very large. And that means there's a lot of variability in there. And that's also indicative of an instability. Like they can't seem to compensate even for an abnormal movement pattern. When I look at this guy right here and I look at this position, negative 23.4. So this is the orientation of the foot relative to the ground surface. And as you can see how far it is away from that normal trajectory. So this one actually is normal, -4. So that means there's still going to be a slight calcaneal inversion. -23.4. So that's very dramatic. He is way outside of what's considered to be neutral or a normative value. But you can see this line is very, very tight. That tells me that he's good at this. Like he's so used to walking that way. That's why he's capable of walking that fast. But here's part of the problem. When we look at the foot progression angle, on that left side, he's got a -6.5 degree foot progression angle. So he is very much toeing in. And so he does not have a good capacity to keep that foot in that sagittal plane. And that dramatically affects his base of support, as we saw with the gait line or his center of pressure. Then we can look at the steppage and the clearance. And just a note, so his circumduction looks okay. It looks fine. I don't have a problem with that. And then we can look at his minimum toe clearance and his steppage. I get the data on my report. I don't know why it's not showing up right here, but he actually has normal toe clearance, right? Which is good because other than that, that would be very problematic adding all of these other features. But when I see everything else that we just looked at, his foot orientation on the right, I expect that it's a little bit high. Just he's compensating for the abnormality that he has on that left side. Okay, so what did we do to this patient? So I mentioned a little earlier. So the the facility I'm working with, the neurological facility in New York, the reason I'm working with them is I work a lot with shockwave and high power laser. And so there's some really good supportive literature on the influence of shockwave, extracorporeal shockwave, radial or focused or defocused, on tone, on the neurological system in particular, and the influence that it has on tone. And so the idea was, can we reduce this person's problem as he's approaching? He's really a fall risk. And so what we can do here is I can click on these three dots and I can click on compare. But before I do that, I want to show you this filter mechanism. So the filter means that you can click on filter and it's going to bring up what we consider to be associated with the neurological, right? And it's really just everything I talked about, which is good, I guess, right? So so you can create these filters. And the reason I'm also bringing this up is we've got a new release coming up, and the new release actually is going to have a fall risk score. Now, it's different than what I'm showing you. I'm going to talk about that in a second as well, because the fall risk score is going to be using a very important component in the data that's collected, and that's looking at the variability, because that's really important. Like I said, is their ability either to be too tight or too dispersive. It's too great. So I'm going to put that back on the normal, which is by default. So if I click on these three dots up here, you can do what's called a compare. So this allows me to compare two different analyses side by side. So it's going to populate the one that I just showed, and now it's going to take and add a follow-up. So what we did was I did no manual therapy. All we were trying to look at was the influence of tone on shockwave. So we did focus shockwave at the C5, C6 level I did that for the heck of it, but mostly I wanted to do his lumbar spine. The lumbar spine we did in the paraspinal region utilizing radial pressure shockwave therapy. And so the idea behind that, and you can take that a step further because you also really would want to do this on the muscularity in question. And there's two ways to kind of approach that. One is on the belly of the muscle, influencing the motor point where the muscle spindles are going to be predominantly activated. And then also looking at the musculotendinous junction where we find the Golgi tendon organ concentration. But it's not about that. But anyway, that's what we did. And so we can look at what changed. We were in the clinic, so rather he walked a little bit more, but he was I got done treating him in all of 10 minutes. And he said, I don't feel any different. And I said, well, I'm not looking for you to feel anything. And in fact, you're probably not. So he was just kind of walking because he was, what's the point? So we did make some slight changes in his symmetry. So the symmetry is ground contact and swing time, and that's where that comes from. He walked a little bit slower, but again, it was self-selected. I wish he walked faster because I honestly think that this also would have improved even more if I could. And this is where, if I put him on a treadmill, that could have been a better control with regards there. So what we see here, so this is the 49 inches on the left, the affected side, 47 on the right. And then after treatment, we actually got equal stride lengths. And so it equalized. We didn't see any difference in the stance and the swing phase. And this is where it's important too that, when you do something, it's challenging to think that, you're going to change everything all at once. And I wish we could do that as clinicians, and, we would be even more rock stars. But so we did see some changes in that stride length, which again was important because that's one of the normal factors that we're looking at. If they do that long enough, and this is why I like to have people train some gait on a treadmill, is controlling that speed helps to force some of that. And that's where we can also correct things like stance time and the swing phase. There's a confidence thing too that you need to work on as well with the cognitive aspect. So now we can look here, and this is interesting because we start to see the shift over to the first and second ray with the toe off. And again, that's what we want, and that's going to be a little bit normal. And we're going to see why here in a second with regards to the pronation and the supination. No change here. I wouldn't have expected it because he was normal. And then what we're looking at here, so this is the heel strike foot in. On the first one, we saw that very dramatic negative 23.4. We saw a reduction in both. And I'm going to have to pull it up so you can see that a little bit more visually here in a moment. Actually, let me pull that up right now. So this is what we saw from heels, and it just shows that single line trajectory from heel strike to toe off. And here we are here. And I want you to notice what else happened. We also saw a change in that. This is the standard deviation I want to see. These are the standard deviations I want to see. These get too tight up here, and it tells me he is so used to walking poorly that that's going to be an effort and it's going to take some time to correct. But even after that one treatment, we saw what, a 4 or 5 degree change. And that's very positive, but even more positive is when we look at the foot progression angle. So the foot progression angle went from being way outside of what we consider to be 2 standard deviations of normal. So typically -2 to positive 14 degrees considered to be normal foot progression angles. So he actually went from -6.5 to -2.1. And that's actually a really good thing because that's part of his problem in being that fall risk, the way that his foot comes in ground contact. We also normalized these heel strikes, but again, this is on the normal side. Still a little bit high here, but again, that's because he has a relatively short stride length relative to his speed, but that can come with actual confidence. So I want to go back to I'm going to skip the dual task, but basically that's just increasing load, or you can use an overspeed. That's where the treadmill comes in. So the summary in so what I did earlier was I created a fall risk profile. And so I have a scoring strip, and it's based on a 10-point scale. The lower the number, the lower the fall risk mechanism. So just in this one treatment, he went from a 6.4 to a 3.4, right? And again, this is over the data. Now, I don't use this as my own fall risk profile because this is not how it works, but it's the performance-based outcome measure aspect of what that might look like. So the Center for Disease Control, they use a program called Steady. So Steady utilizes things like the timed up and go test, balance testing, and things like that. So we still utilize some of that, but I like this performance-based outcome measure because it does a really, really good job at highlighting those sorts of things to the patient. So there's still a risk stratification system utilizing Steady, or I'm sure y'all have some of your own as well. But this gives me some really good insight in looking at the gait level of control. And it also matches up with something that's also technical, which is the gait variability index. And that will bring me to, I'll quickly discuss, So I hope I'm not in trouble. I might have let the cat out of the bag a little bit. I'm not sure why that's a saying in the United States, but it's a way of saying that I may have spoken too soon. But so an update that's coming very, very soon. We're looking at gait variability index. So the GVI is going to be in there, and then there's going to be a fall risk. So the fall risk is utilizing the information, but it's adding that variability index, which to me is very, very important, because that's the sign, that's the supportive nature that we have. So what it's going to have is it's going to have a fall risk profile from a scale of 0 to 1, and it's going to have a dial very similar to the speed or the symmetry. And so it'll be automatic, and it will calculate that based on the variability that we don't have in all the metrics. The only one that we represent variability is in the pronation supination with the standard deviations, but it's going to take the data from all of these metrics and biomarkers and generate that score based on what's known, the gait variability index, and create a fall risk profile assessment that is going to be very similar to the different tests that people are using to provide something very similar. So I'm excited for that because that's going to make things a little bit easier. And I think we're going to see that maybe in February. So let me do this. Oops, I went a little bit over the 3/4 hour, but I'm trying to get back to that. All right. So in the chat or there's a question section in the lower right-hand corner where I'll post a question that says, post here. And you can send a question if you have questions. I know some of you probably might want to go have dinner or go to bed. So you can also email us questions, which is our email in the chat, Rana.
I'm going to add the email in the chat. So okay. You could email us if you have questions. If you would like to share an analysis with Dr. Chris so that he can answer a few things on it, or if you would like to share an analysis that we might use in a future webinar, and you could as well request a certificate for attending this webinar. So we will be replying to your email and sending you your attendance certificate. And even for those who did not attend this webinar live, and they would watch the replay using the Livestorm platform, so we will get a notification that they have completed the webinar, and we can provide the certificate as well.
Yeah, and you can, if you send an email, they can forward any questions or communication to me as well. So feel free to do that. And do. And also there's where the link will be posted, and also you can ask if or connect to the YouTube page, and there's a lot of the ones that we have done in the past as well. Can we get access to the doc? Yes. So I'm gonna share this with Rana, and Rana, the education department will then. So if you use that email, then you can ask for any of those documents, or again, any questions you might have. That was from Daniel. Yeah.
So by the way, once you register to the webinar, you will get a link, an access link to view the video replay. But also in few days time, we will add this webinar to the YouTube channel, and it will be on our YouTube channel. I will post the link of the channel here in the chat, so you could go and check our interesting playlists for previous webinars and for very educative short videos, also mostly prepared by Dr. Prue, where it would really like guide your analysis process. So I'm gonna just add the link here, the link to the YouTube channel here. It's in the chat now. Ramsey, you don't have any questions? Usually you're always asking very interesting questions.
He probably dropped out. He's like, I know this. we always appreciate you though, Ren.
Yeah, definitely. And I see that he's still there, so a question might be on the way. You're welcome, Georgios.
Absolutely.
You're welcome, Keelan. Yeah. And please don't hesitate to reach out if you would like to have an attendance certificate for participation.
Yes, and again, thank you all. I greatly appreciate your time. I love sharing information. If we can do anything we can to, take care of people a little bit better in your corner of the world, then absolutely. And that's why I love communicating with folks, because I'll learn something from you as well.
Please feel free to share with us any interesting cases that you would like us to discuss in the future, because this is how we all share and learn.
Yep, absolutely.
Sabrina as well. Okay, so if there are no more questions, then thank you also, Dr. Chris Prue. Thank you, and thank